Alrighty, it looks like everything's starting to slow down for a number of attendees, so I'm going to go ahead and get started today. Again, this is the Society of Thoracic Surgeons, our very first congenital heart surgery database new data manager webinar for Thursday, August the 27th. So thank you everyone for joining. All right, again, hi everyone, and again, thank you for joining and taking time out of your schedule today. If you have colleagues that were unable to join today, please know that this webinar series will be recorded, and the recording as well as the slide deck will be posted out on the STS website for your review. On the call today from STS, we have myself, Leanne Jones, the database manager for the congenital heart surgery database, as well as the general thoracic database. We have Carol Crone, our senior clinical manager over all of our STS national databases. From the STS, let's see here, we also have Addie Dolan on the call. We also have Sydney Clinton joining us. From our IQVIA team, we have Jean as well as Joe joining the call today. And then we also have two of our core group members. We have Chastity Wellness and Leslie Wacker, who will be helping to present today on the webinar. So thank you everyone for joining today. For today's agenda, we'll go ahead and cover, I'll do a few more introductions, and then we'll start with an introduction to the STS as well as the STS national databases. We'll go over the role of the data manager. We will cover how to read the data collection form. We'll review variables that are required. We'll discuss an introduction to the data specifications as well as our software specifications. We'll also review the training manual and how to best use the training manual. We'll go over the process for submitting clinical questions. We'll discuss keys to abstracting data. We'll discuss building a relationship with your surgeon, which is very key. We'll also review ensuring clean data. We'll go over some data submission guidelines. Data submission deadlines rather, as well as we will review additional STS resources that are available to you. So again, first I wanted to give you a visual representation of your STS National Database team. We have Donna McDonald, who is our Director of Quality. We have Jane Hahn, our Associate Director of Quality. We have Carol Crone, again, our Senior Clinical Manager for all of our STS National Databases. Catherine Hollyfield is your contact if you have any questions regarding PDMAX or InterMAX. She is the National Database Manager for the InterMAX and PDMAX databases. Again, we have myself. We have Emily Conrad. She is our Senior Coordinator for the STS National Databases. Emily is our contact for anything regarding AQO, so she is super busy getting our very first virtual AQO up and planned that will be coming soon. And Emily is also responsible for the STS audits. We have Derek Steck, our contracts manager for the STS national databases. If you have any questions regarding your participation agreements or your contracts or any questions regarding future contracts, Derek would be your contact for that. We have Addie Dolan, and she is our STS National Database Coordinator. Addie is your go-to if you have questions regarding your participant contacts or getting that information updated. Addie is the staff person that you'll be working with for your participant contacts. Also on the call today, we have, as I mentioned, Leslie Wacker. She is a core group member from the University of Michigan. And we also have Chastity Wellness, again, one of our core group members from Phoenix Children's Hospital. So this is our team for today, as well as the STS database team that you will continue to work with. All right, so next I'm going to turn things over to Carol Crone, our Senior Clinical Manager, to give us an introduction to the STS as well as the STS National Databases. Carol?
Great, thanks, Leanne. Hi, everybody. This is Carol Crone. I'm the Senior Clinical Manager for the database. I just wanted to give you a quick rundown of the STS and the start of the databases and why they're important, not just for research, but for improvement of quality of care for our patients that are placed in our care and we get the opportunity to serve. So I wanted to run through that, and we'll do some polling questions as well. So if you're able to, you'll see the polling question pop up on your screen. So we haven't launched them yet, but we'll get there shortly. So the STS was founded in 1964, and the mission of the STS, our mission, was to enhance the ability of cardiothoracic surgeons to provide the highest quality of care through education, research, and advocacy. And we can't get there without data. And we know that as we get more into the big data community, how important it is to be making evidence-based decisions for our patients. So this is where you come in, and why it's important that it's great that you're able to join today to get a better handle on the database and abstraction. So we'll get more into that in a short while. Today, the STS has more than 75,000 members in 99 countries, so we're national and international. We're a rather small society. We have 65 employees based in Chicago and the DC area. The DC area is our advocacy, and they are, they go to the Hill for us. And we, compared to other registries, we are a rather small registry, but we're small but powerful and mighty. The first database was the adult cardiac database, and that was started in 1989. The reason why that database was started, and kind of where we also evolved into having a general thoracic and also a congenital database, was in a response to HHS-HCFA, which is now CMS, and where they were putting out really terrible outcomes about cardiac surgery, and those outcomes were not risk adjusted. So what it looked like is that we were doing surgery, all the patients looked to be the same, at least this is how it was portrayed, and that we had really terrible outcomes. And when the STS surgeon leaders got together and said, well, we know that that's not true. We know that some patients are very sick, and we're doing surgery on these patients, and sometimes we have great outcomes, sometimes we don't have great outcomes, but overall, STS surgery or cardiothoracic surgery is a safe and viable option for patients who require that intervention. So in response to the CMS coming out with that, we developed this database, and there was also 3 other things that were going on around the same time. One was there was malpractice lawsuits related to the misperception of the risk associated with surgery, which is similar to what the CMS was showing. And then we had JCO came out and required all health systems to have a QA program for surgeon recredentialing, and then there was threats to reimbursement based off of what CMS was putting out in the media. So that's where we are with the purposes of the CMS or with the STS database, and you can go to the next slide, Leanne. The accomplishments of the database, when we get all of this data and things that we're able to do with it and things that we have done with it, which are published, is that we have definitely improved patient outcomes and patient safety through the people and sites participating in the database, giving us our data. We've improved these outcomes on a national level as well as regional and local levels. We've developed practice guidelines. 2 examples are blood conservation and antibiotic usage. And we also have voluntary public reporting. And it is it's well researched that sites who publicly report have better outcomes versus sites who do not publicly report. So those are 3 accomplishments or 3 highlights of the database. The congenital database was started in 2003, and it currently has 121 total sites, both national and international. We have 118 North America, which is US and Canada, and 3 international. We have an anesthesia section that is a separate add-on feature for the congenital. We have 67 participants, so that's pretty great. About over half of all congenital sites are participating in the anesthesia section. 405 surgeons and 660 anesthesiologists. We contain more than 540,000 procedures on more than 330,000 patients. That's a lot of data to be able to do national, international, and we're talking on a world level QI projects and improve outcomes, procedural outcomes for these small little patients that are being cared for. 88.1% of all congenital participants participate in our voluntary public reporting. Next slide, Leanne. So for the data abstractor, it's interesting to see. I don't know that everybody can see what their qualities are when we start to look at everybody. what a common theme is around data managers and our qualities. You're smart, you're creative, you're meticulous, as the guy cutting the grass with his scissors, organized, very passionate in a good way about making sure that we're getting good data in and that we're using that data appropriately to make evidence-based decisions for the patients we're caring for. Most of you are nurses, some of you are in healthcare management, specialists, or you hold other roles, but overall as a team we all make a difference. And you have to think about this on a world level about how the differences impact the care of these patients that we're collecting data for. So I just launched a poll just asking what your background is, and this just kind of gives everybody an idea of who's on the call. Mine, Leslie and Chastity's background were in nursing, and I'm in public health, and Leanne's background is in IT, and she's been with the database for a very long time on the DCRI side. And if you all don't know, we have a data warehouse. Right now it's IQVIA. Prior to going to IQVIA, we were with DCRI, Duke Clinical Research Institute, for both our warehousing and analytics. When we switched to IQVIA to progress the database, even though it's a little painful right now, but we went to IQVIA to progress the database, and there's a lot of great things that will be coming in the future. Leanne came over to STS from DCRI because she's, well, we love her and she's a great resource and she knows the database like the back of her hand. So that's where Leanne came from. So, all right, so I think we have, if anybody's any more voting, I'm gonna stop the polling here and share the results. So most folks are nurses, 71%, or 15 out of those that reported, and we have a physician on the call. So that's great. And we can go to the next slide, Melanie. I'm sorry, Leanne. I know your name. So So the data abstractor role and manager role, this is kind of the background of, or the kind of the focus. We have a lot of tasks. Your role is not just to look at a chart and pull data out. We abstract data, of course, but also submit it, clean it up, make sure that we have good data, that what we're using for analysis is accurate, and not just at your level, but if your data is not clean data, it impacts the STS national data and impacts decisions that are made. So it's important to have clean data. We do QI improvement projects nationally, regionally, and locally. Of course, charting, you can help improve charting if things are not abstracted correctly or according to definitions. You can improve that at your site. You can work with your nursing team, your clinical nursing team, and help improve that. We help our sites with best practices by sharing STS data with sites so we can improve best practices on the local level. We can help improve workflow on units. We are a source to bring teamwork together between the OR side and the nursing side. We have quality assurance meetings with our surgeons and the supporting departments, and then we also work with our administration on, we have on star ratings, but the congenital report, we do not have star ratings. So administration reporting on our outcomes. We go to the next slide, Leanne. And I think, hold on one second. So this, I wanted to launch this poll as well. This is asking what your current role is at your hospital. Are you do you only do data abstraction? Do you hold other clinical responsibilities or other non-clinical responsibilities? I know when I was at the hospital level, I still worked in the CVICU, and did my data abstraction, which was great because I still was able to have that clinical experience. And we all have different roles at our hospital. So it looks like, let's see if anybody else would like to vote here. We'll let it run for just a few more seconds before handing it over to Chastity and Leslie. So I'll share these results. Most folks, in addition to data abstraction, have other non-clinical responsibilities. Most likely you're abstracting for other registries, or you're doing other quality projects at your hospital. I'm now going to hand it over to Chastity and Leslie, both who are members of our core group. And for those of you who don't know, our core group the STS, we have a surgeon-led task force who helps, how are we using the data? They help make the big decisions, and ultimately the database is the surgeon's database. So the instruction and direction comes from the surgeons. We have a group of core group members who review the frequently asked questions that are submitted in. They work very closely with the surgeon leadership to help bring the data manager aspect to some of the decisions that are being made. And Leslie and Chastity are two of the leaders in our core group that have been really helpful for the STS and have a great relationship with us. So I'm really excited that they're able to join today and present to you as the new data manager and help bring you on board and make you feel more comfortable with your position. So I'm going to hand it over to Leslie and Chastity. Thank you.
Thanks, Carol. So this is Leslie from the University of Michigan, and we're going to start here with how to read the data collection form. And just for reference, this is available on the STS website under Registries National Database, and you'll click on Congenital. It's available in both a Word document and a PDF, so you can, and some sites do, print this off and fill it in per case, but it's also recreated by your software vendor, and so you'll be entering the same information into whatever program it is that you use to submit your data. And the way that we look at this is in different sections. This is just a snippet of the first page, administrative, demographics, and birth information, as you see here. It's updated every 3 years officially, but what you'll notice highlighted in yellow in the middle of your screen are additional fields for COVID-19. Of course, we're going through this pandemic, and so we've added the option using temporary codes, not adding new fields, to be able to answer some additional information regarding your patient status in COVID-19. This one in particular, version 3.41, began in 2019 and then is set to be updated the beginning of 2022. If you take a look at the left side of that form, you'll kind of see what we're going to refer to as parent fields. And sort of in the middle, you'll see birth location known, a yes or a no. And that's what we're referring to when we talk about later in the slides as a parent field. You're going to say yes or no to that, and then that will help to guide you through your data abstraction as to whether or not you need more information. So obviously saying yes means you're going to answer a few additional questions. Leanne, you can go to the next slide. So that form is pretty long. I believe it is 40 to 50 pages. And according to the STS, all of these variables are equally important and required. But like I mentioned, there are parent-child relationships, which will help you to reduce the number of fields you're actually answering per case, and then also thereby reducing the number of missing fields you'll see in the feedback summaries and feedback reports when you submit through the IQVIA portal. It's important to not omit fields that are in our main sections of the feedback reports. These include our mortality analysis, which is kind of how generally we're judging programs against one another, our case mix models, benchmark operation reports, and lesion-specific reports. All of those will kind of be subsets of your overall feedback summary that is provided now on the IQVIA website. These are described in further detail in what used to be our I'm blanking on the name, our interpretation guide in the STS feedback summary, and it will now be kept in the library on the IQVIA website. All of these fields should be completed consistently internally so they're meaningful over time. And what that means is if you get a specific case that is really confusing, we could encourage you not to just make a decision based on that one case, but rather submit a question if you're confused, or try to answer it how you've always answered it for every case, so that when you look back over 4 years or even further over the history of your program, you know that each field has been interpreted the same way. You can move to the next one, Leanne. So in order to get some more information on how to collect the fields, we have 2 different documents that are available to you also on the website. They're the data and the software specifications manual. These are also updated every 3 years, and it will give you a variety of different pieces of information. So there's going to be a definition, which is sort of your overall, what does this field mean? Allowable values, so there's accepted values and then sort of in and out of range values. What type of field we're looking for, so this means, is it a text field? Are we looking for you to answer CPV or no CPV, or are we looking for a number, a 1 or a 2 or 0? If it has a parent or child relationship, it will tell you what the parent would be. So you're only answering certain fields if you've answered yes to another field. And then the software specifications also guide your vendor in how they can build your software that Leanne's circling around there. All of the different details and what that means. If you answer yes, then what happens after that and what's required of you. We can go to the next slide. Thanks. So the software specifications are sort of the official documentation of the definition, and that changes every 3 years. But in between, we have the training manual. So this is a kind of replication of the specs document, but it gives you additional information. It provides an intent and clarification to some fields. So when it says, did you intubate the patient, you might have additional information, meaning we want the intubation time closest to the operation. These are updated whenever you submit an FAQ. So you can submit as often as you like, of course, your FAQs, but we answer them approximately once a month. And what you'll see here on the screen in red is the most updated information on that variable. You should refer to this and your specs document, but this is probably the most important with the most recent information as you're abstracting each case. So what I like to do personally is keep this up sort of on one screen so that as I'm going through, if I have a question, I can easily refer to the training manual to see if there's been any kind of clarification over time. Go ahead and the next one, Leanne. So when we talk about allowable variables, this is listed in your specs document as well. And what you see here in green is sort of on the left side of your screen is sort of your normal range. That's where we expect the value to be. Outside of that is what's allowed. That might produce a warning when you submit your data to IQVIA because, you know, this isn't the typical range that we see, but just take a double check. Make sure that that's the right number. It might just be a typo. And that's the yellow that you're seeing. And then in the red on the outside most portions, what you're seeing are what you would then see as a critical value in IQVIA when you submit your data, and it's not allowed. We would never expect to see that data out there, and we're assuming it's a mistake and it should not be accepted into the database. You can go to the next slide. Sorry, Leanne. Okay, so while you're abstracting data, if you do have a question, of course, first refer to the training manual because someone might have had the same question. If you don't see an answer there, you can go again on the STS website and submit a clinical question. You'll need some information to do that. You'll have your participant ID. It's a 5-digit code referring to your hospital or your surgeon group. It starts with a 5 for congenital. You'll want the short name and sequence number, which can be found in the specs or in the training manual. And we want you to provide as much information as you can about your question without divulging any PHI. Next slide. So those will be submitted to the core group. We'll review all of your questions as they come up, and then we have a call every month. We may need to ask you for more information, which is why we say put as much in there in your initial go as you can. But we review the questions. We do our best to answer it as soon as we can. But there's also times where we need to triage your questions to a surgeon or to someone with IQVIA or even just someone at STS or anesthesia who may have more knowledge and information on the question that you're bringing up. Most of the time, there's data managers on the call who are helping to take additional notes and pulling up past versions of FAQs and our past versions of specs so that we can try to be as consistent over time with our answers. So generally speaking, you're going to submit an FAQ that the core group is going to go through, talk about what the question means, and then kind of what the circumstances are and give you an answer. You'll get an answer via email, and then we'll publish it like we showed. I go into the training manual in that red section for the most up-to-date portion. But again, usually we aim for within 30 days. If you submit your question, for instance, we don't meet for another few weeks to talk about it, there'd be a little bit of a delay. But of course, we might come back to you for some additional information because we want to get the answer correct. We don't have instances where we answer your question one way today, but someone else brings up a question that's similar, but not the same, and we
Hey,
answer it
Leslie,
differently.
sorry to interrupt you, Carol. Your volume, sorry about that. Your volume is going in and out.
Oh no.
It just started.
Okay.
Yeah, sure.
So hopefully you heard all of that I just mumbled about, but essentially the gist is it can take up to 30 days. You should hear from us in that 30 days because we might ask you for more information, but ultimately you'll get a response via email, and then we'll publish the response for everyone to use in the training manual. And that's updated once a month. And I think the next slide will go on to Chastity.
Yes, thank you, Leslie. For those of you who don't know me, I'm Chastity Wellness, and I hail from Phoenix Children's Hospital. And so what I'd like to talk to you about, since Carol gave you a nice introduction to the database and Leslie went through kind of the tools of the database and how you would abstract data, I'd like to give you maybe some, share more keys to data abstraction and what makes you successful in this role, as well as other resources that can be available to you through the database. So I'd like to start with, and it's not written on this slide, but I think organization is the biggest thing, attribute that you can have or develop along the way as you're becoming a new data manager. I think that if you have an organized and consistent approach to what you're doing and how you're doing it, although with the understanding that you may have to change how you're doing something over time, and that's okay, but just as long as you have an organized approach to what you're doing and that you're consistent within your own processes at your center, it will make you more successful. So be consistent where you obtain your information. So as you see, you're going to use the data collection form. So you know what your collection, or you're just entering directly into your software, which I think is how many of us do it. And what you need to know is what data are you going to use to obtain this? And in our EHRs or paper records or whatever you have where you're going to collect your data, you have different sources available to you. So you really need to pay attention to these sources. So what I like to say is that you find your gold standard. So if it is a field that is coming from the OR, from the surgeon, then I want to use the surgeon's dictated note to find that piece of information. Likewise, if it's perfusion data, I want to use the perfusion record to get that data. I know the surgeon may dictate some information about perfusion, and perfusion may add some information about surgery and anesthesia, but I want to go to each of those places as the source document to get the best or gold standard of my information. I also want to be consistent in doing that. So today I don't want to take something from the surgeon's note that tomorrow I take from the intensivist note or the cardiologist note. I always want to be consistent. So when I hire new data managers, one of the first things I have them do is actually go through the EHR with the data collection form and all the definitions and tell me where you think the gold standard is. And so when I hire someone from outside of the organization, this is much more fun than when they're internal. But internal, sometimes if you hire someone from, say, the cath lab or the ICU, they know places about documentation that I may not know on my end, and we come up with a new gold standard. But I think the point is understanding in your chart where things are, where they're documented, and what the gold standard is. So my big examples with this would be things like your birth records or birth history. I work at a hospital that does not birth babies. So if you didn't come to us as a neonate, I can't see your birth records, but I would consider all of those birth related fields, their source documentation or the gold standard, to be those birth records. And so I search for those first. If I can't find those, what's my secondary gold source? So I would say next would be my neonatology notes. The patient spent some time in our NICU and neonatology. And then from there, go further away from the source. But no matter what, I look for the birth records first and then move out from there, hoping that along the way I find something as close to the source as possible. Another example that I would give to this would be, say, something like extubation time. In my own personal EHR, there are multiple places where extubation date and time get recorded. And if it's in 3 or 4 places throughout my record, what do I consider the gold standard? And so I really have to think about this and decide who would be the most accurate, who would be in that patient room or in that patient environment at that moment in time and is largely responsible for documenting that data. So it may be different by hospital. So Leslie may pull out this data from, the respiratory therapy sheets, and I may pull out this data from the nursing documents. Regardless, the gold standard could be in a different place in a different hospital. You have to know your sources and what would be the gold standard in your facility. Keep your training manual open at all times. Whether you are an experienced data manager and have been doing this longer than you'd like to share, or this is your first day, I would always suggest having the training manual open, because you'd be surprised how quickly I, in my head, can go down this rabbit hole of did they mean this? Have I been doing this wrong for 10 years? And so it's nice to always have that training manual there. I never assume that because I've been doing this a long time that I know everything in that, 500 plus page document. If you don't understand something, you can definitely ask your surgeon. However, I will point out, and it's coming on a future slide, your surgeon doesn't know the rules of the database. They know the rules in the game of cardiac surgery, and they're very good at it. But it's why they pay you to be kind of the data guru or the data expert. And so I would call this dial a friend. So whether it is other people that you network and meet along the way in this journey, whether it's a core group member, whether it's submitting a question to the core group, and then also aligning yourself with people in the hospital. So for example, when new fields come out every 3 years as they update in the database, and say there are new perfusion fields or new blood fields or anesthesia fields, I meet with each of those groups and say, I now have these questions to answer. I'm not a perfusionist. I don't necessarily understand what this means. Can you help me? And there have been times where I definitely would have abstracted incorrect data had I not met with perfusion or anesthesia to find out how we do something or what we do. And in all actuality, even so from anesthesia to perfusion, they went on to change their own documentation forms to incorporate some of the STS fields that I need or that I would struggle getting out from the fields and from their documentation, given I'm not a perfusionist or anesthesiologist, which was incredibly helpful and streamlined my data collection in Phoenix tremendously. So partner with people in and out of your hospital. And of course your surgeon, and that'll come up on another slide. Do not guess if you don't know something. Guessing is bad data. And so you're better off being, very organized and consistent and trying to find the answer. And if you can't find it or you don't have the answer, don't just answer no or yes or whatever you think it might be, or you're assuming that I know nurse so-and-so up in the ICU and she would never do this, so the answer must be this. That's never the way to collect data. And so if you can't find an answer and you really don't know, you can select unknown or leave it blank. Some vendors don't have unknown necessarily built in, but we don't want to guess. I think the other thing that's not on this slide that is very important to understand as a new data manager is that medicine, as you know, is not static. Pediatric cardiac congenital heart surgery is also not static. So we can't expect our database to be static. We want it to always evolve and always be moving and always, when we're suddenly doing new procedures or trying out new things in cardiac surgery, we need the data to be reflective of that. So the data will always change. And so as we're going through this IQVIA transition, I know that there are bumps in the road and they're being worked out, and maybe not as fast as everybody wants them to be. But in the end, we're trying to move the database essentially into its next generation, right? Like we want to be able to view our data in real time and view our data in aggregate, compared to other programs in real time. And so we're finally getting there. So the database will always move, will always change, just like healthcare always moves and always change. We do different things today than we did 5 years ago, than we especially did 10 years ago. And so I think it's really important to go into this knowing there will always be changes and not to be frustrated with the fact that the database will change. Next slide, Leanne. Working with your surgeons. I think this is one of the most key things that you can do as a data manager, is to develop a strong working relationship with your surgeon. Some of them are more engaged in the data than others, but I think that there are some things that you can do to always keep your surgeon engaged. I would start out by setting up ongoing meetings with your surgeon. So at a time where they're not in the OR, so if there's a day during the week or an afternoon, or whatever, where they're not in the OR, that you always keep them captive, for an hour or half an hour. And you come to them and say, what kind of things should we talk about during a meeting? Do you want to review all cases? Do you want to review all complications? Do you want to review all mortalities? However you guys want to do this is really up to you. But I think if you always come with some data prepared, some questions prepared, that this will help you build a relationship with your surgeon. I think it's important to understand that they don't know the intricacies, the rules, how things are assigned in the database. That's your job. And Leslie and I always like to say, it's why you pay me. I'm the one that's sitting at all these meetings. I'm the one that's figuring out, what the definitions are. I need your help, surgeon, to help me check the correct box or come up with the correct primary procedure and things. And so I know how to apply the rules. I have no idea what you did in the OR, and I don't know what to think of this repair. So I like to say to my surgeon, I don't know where the blood's going. Tell me where the blood's going. Because then I usually can figure out what the correct procedure and diagnoses are, if he would just tell me where he routed the blood. And so being able to have, a good relationship like that, I think is very important. Don't be afraid in your meetings with surgeons or anyone else in your facility to say you don't know. Say you don't know the answer to this. However, you know where to get the answer. And so whether that is through networking, through your core group members, through asking a question, dialing a friend, you'll figure out the answer for them. No one expects that you're, walking around like an encyclopedia and know this database inside and out, especially when I just told you that it will change and change often. You just have to know how to get to the correct answers. Be prepared for your discussions and be organized for your discussions with the surgeons. They have limited time, they're busy, and like I said, some are more engaged in data than others. And so the more organized you are, the more that they'll enjoy meeting with you and reviewing the data. Maybe develop a template for how you present the data to them, but especially if you're involved in any type of data presentation outside of just your surgeon themselves. So coming up with consistent templates for how you present the data. Become an expert of the data. So be very familiar with all the tools at your fingertips and familiar with how the database is moving and where things are going, and always relay that to your surgeon. So my surgeons don't necessarily know what's going on with IQVIA. And so, maybe every few weeks I send an email that says, hey, this is what's going on. Don't worry, you'll see the platform soon. And then they feel comfortable, like they know what's going on, and, with limited detail. They don't need to know all the intricacies or what's being worked out by IQVIA, but they're aware that something is coming and they're excited for it. I think also you can partner with your nursing and OR staff. And I think the big ways here are when you're collecting data, you start to see discrepancies in data and you start to see errors. And what I realize is it could be a full-time job for you to, essentially abstract data to help nursing documentation. So I try to focus on the big things, what's glaring, what can I not tell from nursing documentation? And I work with mostly cardiac ICU or step down and the OR staff to come up with more consistent documentation. Or many nurses do this, other nurses do that. What is the appropriate way? Where should this be charted, or how can this be charted or be cleaned up so it's not discrepant to what respiratory therapy is charting, or vice versa. Next slide. Cleaning your data. I will be giving an entire, 35-minute presentation on how to internally validate or clean up your data prior to submission to the IQVIA data platform. So I have one slide to present it here, but essentially there is internal and external validation. And what I would say about internal validation is this should happen consistently for you, and you have to come up with when this works for you and in your workflow. And I would definitely recommend prior to submitting your data at Harvest. So can you do this monthly? Can you do this quarterly? How you do it is up to you. And it may just depend on how many cases you have to abstract or how many other duties you have outside of data abstraction that will dictate how often you can clean up your data. And so this is very native to each individual program and how you want to achieve this. I don't suggest waiting until 2 weeks before the end of Harvest and then start cleaning up your data internally. You could potentially have software errors with your vendor to fix, or other data inconsistencies that you'll need to clean up. And so I do suggest having some consistent manner in which that you do these internal quality checks. So oftentimes your vendor has either canned reports that you can use to look at different things like, say, missing data, your mortalities, a case summary report. Each vendor does this their own way. And that's kind of why people pick their vendors based on their strengths and weaknesses of what they offer outside of the data specs. And so it really is dependent on who your vendor is. So partner with other people who have your vendor, and they can say, look, I use this report always. It saves me, so much time, or it saves me greatly. And when they're canned and in your vendor software, they're usually pretty quick and easy to run. And then you can see where your inconsistencies are. Alternatively, you can export your data out of your vendor and compare it to other sources within your EHR. So if I know how many mortalities we're reporting, out of cardiac surgery, I should have those all accurately coded in the database. And, you'd be surprised how quickly you can accidentally scroll and change a field, and, someone that you didn't think died did, and vice versa. And you would never want to submit those mortalities unless you know that they are absolutely correct. And so then what I would call external data cleaning would be when you are harvesting your data or submitting your data to the IQVIA platform. And there are numerous reports, and you're going to get much more information on this on all of our STS calls and webinars. but there is something called the data quality report, which really looks at your errors with each file that you've submitted. Then there's a harvest summary report, which looks at, you can select the dates. And so you can select the entire harvest window, which is 4 years, and look at then the errors and problems with your data. There's also a critical error report, which tells you these cases will not be analyzed. These absolutely have to be cleaned up. And so critical errors can arise for a variety of reasons, which you'll learn over time. They can be vendor issues. And so you would work with your respective vendor to clean those up. They could be that you have data that's outside of the range, like Leslie showed all the way on the red ends, that you've accidentally said that, you know, somebody's temperature was 200 degrees Celsius, and so you need to go clean that up. And so you'll get to use these reports and understand. We also have new reports coming out in IQVIA, and this would include like the mortality eligibility report. And so you'll learn how to use these as you learn to upload your data into that platform. And on the next upgrade, we're going to have some built-in consistency checks on save. So it'll be required to be built into your vendor software that will help you, so you couldn't enter a temp that was, you know, 200 degrees Celsius. Next slide. Data submission deadline. So it's always important to know when your data is due. And so the minute I find out that these data submissions are come out, and you'll receive emails, they get posted on the STS website. Know that for congenital, it happens twice per year. And so I mark those on every calendar I own and put it on a Post-it, because it's the one thing that I absolutely cannot miss would be submitting this data. Your hospitals pay a lot of money to not only employ data managers, but also to participate in the database and to pay your vendors. And so missing out on a harvest doesn't decrease those fees. So you definitely want your data to be analyzed and reported. And so for congenital, outside of this year with the IQVIA transition, it happens 2 times per year, in the spring and in the fall, and you get a data report then associated with those data harvests. So for example, our data is going in right now and is due October 16th, I believe, is the final deadline to submit any data to the platform. And we usually receive a report then by the end of the year. So I don't want to give any dates because I'm not aware of those, but usually it takes a few weeks or months to get the data analyzed, and then the reports posted now on the IQVIA site so you can see your data. Each report also contains 4 years of data that are analyzed. So for this harvest with the data that is due October 16th, the dates will be from July 1st of 2016 to June 30th of 2020. So any surgeries that occurred within those date ranges would be required to be submitted to the database and then analyzed. Voluntary public reporting then is based on the spring harvest. And so for right now, public reporting through the IQVIA transition has been halted, but it will pick up again in 2021, and those get posted on the STS website. Next slide. So additional resources. The best thing I can tell you, as Leslie mentioned, where to go on the STS website to find a lot of information, is bookmark these now, because you don't want to spend a lot of time searching and things, but just start bookmarking the places that you will go. So I have the training manual bookmarked, and I have the webinars bookmarked. Go back to the website often, frequently, and look, when meetings get changed, when meetings get updated, when meetings get scheduled, it gets put out there on the STS website. There are monthly didactic webinars and monthly user group calls. And again, those are posted on the website. Then quarterly new data manager webinars. This is the first one that has come out for the congenital database. And so it'll be quarterly from here. We also have our data quality meeting coming up, and this is a meeting that is specific to data managers. So it's all about data and all about data managers. And so while surgeons do come and speak, especially those that are very involved at the STS level or just in the data in general in their own respective programs, this meeting is not for surgeons. This meeting is by and large for us as data managers. And so there are often really great talks, case studies, people you can ask. This is a great place where you network. Now it'll be a little strange this year being virtual, but I think it'll still be a good meeting, and you'll get a lot out of it. We're going to be reviewing the upgrade. There will be.
Jess,
sorry.
Sorry
Yes.
to jump in here. I think we have a little error on the slide. We're actually this year is not the upgrade for congenital, so it will be more information on other areas for improving data abstraction.
Okay.
engagement.
Perfect.
Sorry.
I apologize. No, there's live content and then pre-recorded content that you can watch on your own, and CEUs that are still available. Also, I think next slide shows you more about the data manager meeting and the dates. So the congenital day is on October 2nd. And if you register now, you can get early bird registration, which is like 50% off. So it's pretty fantastic. And I think that's it. Last slide. Yes.
Yep. Thank you so much, Leslie, Chastity, Carol, everyone for helping with today's webinar. So that's the content we have for you all today. Now we're actually going to turn things over to all of our attendees for our open discussion session. We encourage you to use this opportunity to please submit any and all questions that you have. Please know there's no such thing as a stupid question. We are here to answer all of your questions. So please feel free to enter those into the Q&A function. And please help us, let us clarify any questions that you have. Now's your opportunity. So please feel free to go ahead and get your questions submitted.
Hey, Leanne, thank you. Leslie and Chas, thank you so much. That was a wonderful presentation. Is it okay as we're waiting for questions to come in if I go over to the STS website and do a quick run through of where things are found? Okay.
Absolutely. Yep.
That might be.
I'm gonna stop share.
Okay.
Got it.
All right. So this is.
Good. Thank you, Carol.
I just can't express how grateful we are for Leslie and Chastity. That was a really good presentation. So thank you very much.
Yes, absolutely. Thank you.
Yeah, thank you. This is the sts.org webpage. All the information for the registries are under the fourth blue tab, which is the registries. And then AQO information, the advances in outcome and quality information, can be found under meetings. For registries, you could click here on the national database, and then you'll see the 4 registries pop up here. If you scroll down further on this page, this is where you'll find information. If you are interested in joining the anesthesia portion of the congenital, you could find that underneath join the database. Also, our fees are listed here. We have information on our live webinars. So as an example, if you click here, you'll see all of the webinars, upcoming webinars populate for the databases. And the past webinars are located here under, we have the most recent ones posted along with the PDF slides. And then if you go to the CHSD webinar YouTube playlist, we have a YouTube playlist dedicated just to congenital database. So you'll find all the previous webinars here. And these are updated as we post the new one. The dates for the next upcoming one would be updated. The new data manager webinar will be hosting that quarterly. Same information, but it's a great, once you get in and start abstracting, if you want to join again, and you can, you might have more questions at that time or different questions that Leslie and Chastity and Leanne can help clarify for you. So I'm going to go back here to the STS National Database page, and I want to back on this screen here is you'll find the other important resources. We have transition information for the warehouse to IQVIA. We have data manager education. You'll also find a link to the webinars here, and we have a data manager survey that we do we have the results listed from the previous survey. And then if we go back down here, we have the harvest schedule and information, database forms. If you need to add somebody onto your account or remove somebody onto your account or change access, you'll find that here, and that's the participant form. If you're adding a surgeon, they would need to sign the Schedule A. Anesthesiologists would need to sign the Schedule B. And if you're changing a vendor, that's the vendor licensing form to do that. We also have the link here is for the participant role. So if you're trying to figure out, if you want to add a surgeon, what role do you add them in on the participant contact form? This is the document you would use to see the definitions for those roles. This is back on the STS National Database page, and then we get down into other information. We have information here on AQO, and the STS National Database News is a 6 times a year newsletter that comes out each specific for each database. So congenital has its own national database news. You can find archived versions here for the past couple years. And the new versions are posted here. The congenital one and Intermax are due to come out, I believe, next week. So it will be updated here for July and August.
Mhm.
And if you're not receiving our emails, you'll want to email stsdb@sts.org. And Leanne, would you mind putting that in the chat box so they can see that address?
Yep.
Sometimes sites, the emails get blocked at sites. Either they're blocked because it's coming from a third-party emailing system that we use, or it doesn't recognize it, or it gets put in spam. So we are able to add in additional personal email addresses so you can still get that information if it's being blocked at your site. I'm going to go back here to registries. So those are pretty much the resources on this page. Contact information and then information related to HIPAA. STS is HIPAA compliant. We have all of IQVIA and DCRI are both HIPAA compliant. IQVIA is their level of compliance is one of the reasons why we switched over to them, related to just for safety reasons. Duke is also HIPAA compliant, but we have other working with the government that we needed just a little bit more safety. So we're there. And then here's the link to the Advances in Quality and Outcomes Data Managers meeting. And I think that this was really interesting. We went through this on another call earlier this week. So you'll see here, we have registration, early bird registration through September 7th. So the Advances in Outcomes and Quality meetings, if you've never attended it, or if this is your first year, or you're not sure, the price is $75 for the congenital. It offers CEs, and that's the half price through September 7th. The amount of information, the ability to hear from lead abstractors in the area, in the congenital area, to hear from the surgeons, to be able to interact with the surgeons and the data and the core group members and other presenters. $75 is to really help you do your job better. I think it's well worth it. And in the long run, having this education and this extra information available to you will help you be more efficient at your job. So I think and cause less headaches, help the headaches go away. So I think it's a great opportunity. And if you're able to join and you have your hospital will reimburse you for this, or your hospital, if your hospital will pay, or if you're able to pay that amount of money, I think this is a great thing to try to attend. Each database has its own day. Congenital will be on Friday. And here is just to give you a rundown. I think I can pull up the program here. You can register on this link, and then the detailed agenda is here. So I will pull up. It's kind of interesting. I'm glad that we have this posted already. We will have live sessions and on-demand sessions. So we will have, I believe, 6 hours of content on the live sessions, and then we'll have, I believe, five or six on-demand talks. The live sessions we'll be going over. We have our surgeon leader, Dr. Subramanian, and one of our core group members, Ruthie, will be going over some case scenarios, and we'll be talking about the audit with Dr. Overman, and Angie will be going over common missed areas and how to improve your audit. If you ever are audited, STS audits 10% of sites yearly. It's a random audit. And we audit 10% of sites, and I forget how many cases at sites, but this is if you're able to attend this one, this is great just to improve your abstraction skills. Validating your data by Chastity, that will be a great presentation. Risk model talk by Dr. Jacobs and Janet. Stat score update. Complications by Mina, Dr. Nathan, and what data managers want to know panel, which is an open Q&A session. These are all really, this is the surgeons and the data managers that are presenting here are extremely knowledgeable and great resources if you have questions in any of these areas. The on-demand talks will be FAQ review with the frequently asked questions, and anesthesia component review, a review by Dr. Subramanian with the preoperative factors. Dr. Meyer will give an update on the Harvard project, which is related to the risk modeling. we'll have an update on adults with congenital heart disease and looking at including more information on an upcoming upgrade regarding adults with congenital heart disease. And then Dr. Romano will be presenting on Ross procedures. So if you're able to join, again, you'll find information. It's under the AQO tab. And if you need a letter from us for a justification, you just need to fill out the form that is linked here, and we'll be able to send a justification letter to your facility to help you with that. Again, the pricing, it's a great deal, $75 for the one database. And if you want to attend all 4 of them or more than one, it's only $150 if you register before September 7th. The platform will use Cadmium platform. It's extremely interactive. We're going to have some networking sessions before, during, and after AQO. So it's not just going to be sit there and listen to information thrown at you. We will be interactive. We'll have open Q&A. I really think it's a great thing if data managers, if you're able to join, to do that. Under registries, we also, go ahead, Leanne.
Oh, no, I was going to say we had a couple of questions. I thought we were getting close to the hour, so I just wanted to touch on those if we have before we get close.
Oh, yeah.
The hour's up.
Just one more second. So under the registries tab, go to the general congenital heart surgery database and access data collection resources. We're on current version is 341, and this is where you'll find your training manual, your data collection forms, data specifications that Leslie had gone over, and then other information to help with the CSTAT, the appendix, the stat categories. So, okay, sorry, Lan, go ahead. Sorry for taking too much time.
No, absolutely not. That was phenomenal. That was great. I was like, wow. Yeah, that was great. That was perfect information. Definitely very useful for all of our new data managers on where to locate all of those resources. That was great. So we got a couple of questions. Let's see. Our first question, thank you all so much for this meeting. I've been needing this. How do we know which fields to leave blank versus mark with a 0 versus mark as unknown? Is it better to leave a field blank or mark it as unknown?
So I can take this one, Leanne. Joanne, that's a really good question. Back to what we talked about, what in the specs document where it tells us what the field is expecting, what type of answer. We certainly don't want to answer 0 for something unless the answer is actually 0. So if it's asking you for perfusion time, we don't want to say 0, meaning that it's unknown. We just want to leave it blank. Wherever you have an option to say unknown, like birth history known, I'm sorry, that was a bad one because that would be yes or no. Status, yes, or alive, dead, or unknown. If you don't know, answer unknown. And then leaving blank is really reserved for the fields where you don't have an option to say unknown, but 0 would be false. So some of those would be like your hematocrit. The hematocrit isn't 0, so don't say 0. Just leave it blank if you really can't find the documentation. I hope that answers that question.
Yeah, great. Thanks. Go ahead, Carol.
I'm trying to pull it up so we can see what it looks like. But I just
Perfect.
Perfusion was a hard one. So here's a hematocrit, and here's the values if you wanted to walk through it, Leslie.
Yep, hang on one second. I just got to move my screen around. Okay, so in this case for hematocrit, we have values in here. So the low value is 5 and the high value is 70. So anything less than 5 is going to trigger, number one, it's not going to be the correct answer because the hematocrit is more than likely not 0 if you just don't know. But that putting 0 would be an unacceptable value. So that will give you a critical error, and then that would not be accepted into the database. So if you truly don't know what the hematocrit is, in this case prior to circulatory arrest, leave it blank and move on because you don't have an option to say unknown. This is also going to be helped by your parent and child field. So if you don't have circulatory arrest or cerebral perfusion, then you're not going to be asked. And so, of course, leaving it blank would not mean anything because it wouldn't be an applicable field. And then in that same part where she's scrolling, usual range 15 to 45, we expect to see it somewhere in there. It's not wrong if you go outside of that range because we know that these patients are not always kind of quote unquote normal. But we would expect to see it in there. And so you will get a warning or a flag just saying, hey, double check this and make sure it's correct.
Excellent. Thank you so much, Leslie. We've got one more question. My hospital's quality department is looking for information about the STS national average benchmark for cardiac surgical site infections so that we may set goals for the upcoming year. How could I get this kind of information, please? And
I can take that.
I was going to say, or
okay, go ahead.
No, I was going to say that you are able to do until the platform is out there and up and running where some of this information would be available. You can do a minor data request and just specifically drill down on what you're looking for. So you're looking for a specific complication of wound infections. So do you want, superficial mediastinitis, deep, whatever, or all of them, and for what years? And then I would always include then the type of operation. So are you only looking at index operations? Are you only looking at specific op types, or do you want all op types, all cases? And so you make the minor data request and fill it. There's a form, I think Leanna is bringing it up, where you would request this information and just be as specific as possible to get to the answer that you're looking for.
Excellent. Thank you, Chastity. Yeah, and thank you. And again, Carol is showing that information up on the screen so where you can access the minor data request form. Excellent. I'm not seeing any additional questions come in. I know we're a couple of minutes after the hour. And Carol's showing, again, how to get to that minor data request form on the screen. So thank you so much, Carol. I just wanted to take an opportunity to thank everyone for joining today. Chastity, Leslie, thank you so much for participating and leading this webinar. You guys did an amazing job. We appreciate your help and your leadership and your guidance. Carol and STS team, thank you all so much, and thank you IQVIA team members for joining today. If our new data managers have any questions, please feel free to reach out to us. You can email me directly. Again, we have all of our resources listed out on the STS website. I will put my direct contact information in the chat box if you need to reach me directly. My email is ljones@sts.org. Or you can reach me by phone at 312-202-5822. So please, again, feel free to reach out. And again, thank you everyone for joining today. I appreciate all of your time. Thank you, everyone.
Thank you, Leanne. Great job. Thanks, everybody. Great job.
Great job.
Yeah, thank you.
Thanks, team.
Thank you.
Y'all have a great week.